rolling lush plateaus, all dotted with an abundance of pine trees and crystal clear waters to the north. Desolate, yet alluring and expansive deserts towards the south. In between both extremes, it hosts countless mausoleums, mosques, gardens and lakes. Pakistan's agricultural sector has boosted the country's economy and continues to achieve high numbers of employment. Acres of fertile land, favorable weather conditions, and abundance of rain and rivers are further enhanced with a strong canal irrigation network. The country's manufacturing sector is thriving, with cotton, textile and apparels being the largest industries. Pakistan is predicted to be the world's fastest growing Muslim economy in 2017. Pakistan is also known for its manufacturing of sports goods, which are used by professional teams and tournaments in various countries, including the FIFA World Cup. The China-Pakistan Economic Corridor is an initiative taken by both neighboring countries to explore investment and bilateral trade. It will link the Gwadar port to the Chinese province of Xinjiang and will act as a game changer not only for Pakistan but for global trade as well. There is constant development in the infrastructure across the country. There are 4 motorways connecting city to city, with 8 more under construction. The Lahore Transport Company, in collaboration with Turkey, also launched the metro bus service in 2013. As a country that is just 70 years of age, we have overcome many obstacles in our way. We have done wonders internationally in all sectors. The growth of our infrastructure and incentivized investment policy initiatives are leading to a continuous emerging Pakistan. Pakistan, the land of 1,000 opportunities. Along with its rapidly growing economy and bustling heritage sites, it is home to a number of languages and cultures, as well as being the host to all 4 seasons and possessing a variety of terrains. With natural and historical riches, Pakistan's breathtaking destinations include magnanimous mountain ranges, rolling lush plateaus, all dotted with an abundance of pine trees and crystal clear waters to the north. Desolate, yet alluring and expansive deserts towards the south. In between both extremes, it hosts countless mausoleums, mosques, gardens and lakes. Pakistan's agricultural sector has boosted the country's economy and continues to achieve high numbers of employment. Acres of fertile land, favorable weather conditions, and abundance of rain and rivers are further enhanced with a strong canal irrigation network. The country's manufacturing sector is thriving, with cotton, textile and apparels being the largest industries. Pakistan is predicted to be the world's fastest growing Muslim economy in 2017. Pakistan is also known for its manufacturing of sports goods, which are used by professional teams and tournaments in various countries, including the FIFA World Cup. The China-Pakistan Economic Corridor is an initiative taken by both neighboring countries to explore investment and bilateral trade. It will link the Gwadar port to the Chinese province of Xinjiang and will act as a game changer not only for global traders as well. There is constant development in the infrastructure across the country. There are 4 motorways connecting city to city, with 8 more under construction. The Lahore Transport Company, in collaboration with Turkey, also launched the metro bus service in 2013. As a country that is just 70 years of age, we have overcome many obstacles in our way. We have done wonders internationally in all sectors. The growth of our infrastructure and incentivized investment policy initiatives are leading to a continuous emerging Pakistan.
Hello.
Assalamualaikum.
I'm Sam. Yousuf, how are you?
I'm fine.
Okay, I can't hear you very well. You have to either speak a little louder or
Okay.
closer to the computer.
Can you hear me fine now?
It's better. Do you have a headphone?
I'm not.
Okay, so
Really?
okay. If you don't want to, it's okay. You need to speak up a bit then.
Okay, I'll try to speak louder. Is this okay?
Yeah, that's fine. So we have 5 minutes to go,
sure.
so don't worry. What are you teaching us today?
I'm teaching the approaches to the lateral ventricle, and some of it will be revision of the anatomy that we covered in the last session. But I have tailored my presentation to very basic concepts and approach, precision, and all those elements. Most of which caters to the residents.
Brilliant. I'm just going to see if Azam has joined us.
No, sir. Dr. Azam hasn't joined yet.
What about Hasan?
No.
Okay, so let's. Chandra said he's going to join half an hour late. Hi, Hasan. How are you? Are you? Yeah, brilliant. Okay, thanks. Okay, cheers. Okay, Hasan is joining as we speak. And let me see if I can get hold of Azam.
Dr. Azam has joined.
Brilliant. Yousuf, have you put in some multiple choice questions in there?
Yes, I've put in 5 MCQs, all clinically oriented. So
okay. Would you like to start by revising the 5 MCQs that we did the other day? Do you have those 5 MCQs?
I don't have it right now, but
Ahmad, do you have the 5 MCQs from the other day?
Yes, sir. I have it in the form. I can take it out.
But so sir, I think there'll be a lot of revision in the approach when I'm talking about the approach. So there'll be a lot of revision involved. So I think we'll be covering that.
What I wanted to see is people read during this time. And if you do the MCQs now, and do they improve their score? That's what I wanted to see. Have people read at home or not?
Okay. So maybe we can have the questionnaire filled just now, maybe yet again. But I think we have less participants now.
Okay, so it's certainly coming soon. We have 3 minutes to go. Thank you, Azam. Thank you for coming.
No problem. Assalamu alaikum.
Wa alaikum salam. Hasan, assalamu alaikum. Good to have you.
Assalamu alaikum. Yeah, thank you very much. It's good to be here.
Yeah, and Chandra, I said he's going to join around 5:30, and he said he'd like to show 1 or 2 cases if people agreed and if he had time to just compound everything on top of what we are going to read, so to make sure that we know what we're doing. So it's fun. We will do that, no problem. Okay, do you want to revise? You just you want to start your thing and just go through. You don't want to go through MCQ. It's fine. You can do that. Yousuf, whatever you want to do.
Okay, so just let me know when should I start.
We have a couple of minutes. Azam, you want to start by telling us how we should go about our studies?
I think cross-sectional anatomy and the Rhoton's microsurgical anatomy is a great resource, and there's online you can get all of the Rhoton collection. There's a website now for that. And then there's also so many great videos now with Neurosurgical Atlas and other resources like that have operative videos. I think kind of studying the anatomy and then looking at some operative videos to make sure that that anatomy sinks in and makes sense, I think is the best way of doing it. Should be a keen eye on, pausing the video frequently to make sure that you can identify various structures during the microsurgical dissection in the videos.
Okay, Hasan, your input?
Yeah, I completely agree with Azam. I think that those resources that he mentioned are great. I know that the CNS, the Congress of Neurological Surgeons, also has some educational content that they've made complimentary for trainees. I think that also includes international trainees as well. But just like Azam was saying, looking at the anatomy and correlating it with surgeries is important. And oftentimes, even as trainees, we're hesitant to ask questions, but it's always important to ask questions, no matter what the question is, to your trainers and to your consultants. So always have a keen interest and curious mind to ask questions as well.
I think that's very important to ask questions, because that's how you're going to move forward. And thinking, I saw that case, and maybe you would have approached it some other way. Maybe the boss wanted to do it some other way, and you thought there was some structure in between that could have been saved while we did that way. So one thing or the other. Yeah.
And you'd be surprised how the relationship between I think the trainee and the mentor, it's really important too. There are often times where I've planned surgery and, a trainee will mention something and will alter the plan a little bit, and that relationship is very dynamic and it's a two-way street as well. So don't ever feel that you're, hesitant to speak up or ask questions. It's very important in the learning process.
Okay, I think we are set to go. Yousuf, you want to start, please? Yousuf is our chief resident, and he's going to be discussing clinical aspects of lateral ventricular anatomy with the help of Rhoton. Okay, off you go.
Okay, thank you, Dr. Salman. It does not let me share screen. It says host disabled, participant screen sharing.
Ahmad, please, can you allow Yousuf to share his screen?
Are you not the co-host? Sir,
it doesn't say
you can do it now.
You're the co-host now. You can do it.
Yes, that's okay. Can you all see it?
Yep.
Yeah.
Okay. I'm going to put in a slideshow. Is that okay?
Yes.
Okay. So to start off, today we'll be discussing the surgical approaches to the lateral ventricle. And most of it would be revision of what the basic anatomy that we did the other day with Dr. Yousuf Shaikh. I have tailored my presentation in such a way that it is quite basic. We'll be discussing the important things, but it would mostly cover the basic aspects, clinical aspects, orientation, position, craniotomies, so that all the residents can understand it well. Okay, so the picture itself, it shows that today, since we'll be discussing the access to the lateral ventricles, we can access it through various routes. One of the most common ways of entering the lateral ventricle to address anterior lesions are the anterior transcallosal and transcortical. Then we have a similarly posterior transcortical, transcallosal, occipital approach, temporal, and then we have the anterior frontal approach, which is through the base. This is again a diagrammatic presentation showing access to the ventricular structures. The black line itself shows access to the midline structures, whereas the dotted line shows access with lateral aspect. So we can identify the subfrontal access, anterior transcortical, transcallosal, posterior transcallosal, transcortical, and then we have the posterior access to the ventricular system. So one of the first approach that you would be talking about is the anterior transcallosal approach. This is generally indicated for lesions which are located in the lateral ventricles or within the third ventricle, because it provides excellent visualization of the roof of the third ventricle and both walls of the third ventricle itself. It is ideal in those circumstances when the scan does not show any evidence of hydrocephalus. So in the absence of ventriculomegaly, this approach becomes ideal. Although there is risk of fornix injury, but you can minimize it through various techniques. Generally, the most common approach that we use it for is for colloidal cysts, but we can also use it for craniopharyngiomas, thalamic gliomas, AVMs. So starting off, the first and foremost is the position of the patient. For an anterior transcallosal approach, keep the patient completely supine and the head vertical, because a supine position with vertical head provides better anatomical orientation of the ventricular system. Because we have been studying so far ventricles on the basis of imaging, and yes, and in the last lecture we studied the anatomy. We know that it's C-shaped structure. So in order to understand and have a 3D image in your mind, vertical orientation and supine position is best. Flex the neck 20 degrees and the incision should be somewhere around the coronal suture. Now you need to make your craniotomy predominantly anterior to coronal suture, some of it posterior to coronal suture. So you need to tailor your incision as such. The incision can either be a bicoronal incision, or you can do a horseshoe or a U-shaped skin incision. I generally prefer a U-shaped skin incision because it is smaller and opening and closure is relatively easy. So what craniotomy needs to be done? Now this is the black line indicating the coronal suture. The craniotomy needs to be approximately 75%. That is 2/3 of the craniotomy anterior to the suture one is everything okay? You all can hear me?
Yeah, we can hear you.
Okay, so I'll continue. So as I was talking, the craniotomy needs to be modulated.
Dr. Yousuf, wait.
Sorry, you need to.
Yes?
Yes.
Okay, so as I mentioned, the craniotomy on the medial aspect should ideally go across the sagittal suture. And it should be 1/3 behind the coronal suture. Reason being that when you do a craniotomy and you're accessing the transcallosal space, you will come across multiple bridging veins. They will extend from the sagittal sinus to the cortical surface. Anterior to the coronal suture, these bridging veins are either non-existent or only one or two, which you can diathermize and coagulate easily. But posterior to coronal suture, diathermizing them will possibly risk development of venous infarction. Therefore, this is one of the reasons why you should tailor your craniotomy anteriorly, and ideally it is recommended to not coagulate any of those bridging veins until and unless extreme necessary. So, as
Yousuf, can I just say one thing? So
yes,
I know the classic teaching is that the veins anterior to coronal suture and anterior third of the superior sagittal sinus are of no consequence. But I think as you do this more and more,
yes.
Those with more experience will tell you stories of taking large veins, even in the anterior third of the superior sagittal sinus, and having problems like venous infarction, swelling. So I think perhaps a better approach would be to study the anatomy ahead of time on your contrasted MRI and tailor your craniotomy, either using neuronavigation or using craniometric landmarks, you know, using the Nasion, the the coronal suture as your landmarks to tailor your craniotomy to avoid taking veins. You are right that making a longer craniotomy is better, because then if you're miscalculated a little bit, you can adjust and you can look through a slightly different window. But I, whenever possible, avoid taking any veins at all, because there's often no great rhyme or reason to why patients develop problems afterward with venous infarction or swelling.
Yes.
And for this approach in particular, it's critically important that the brain be relaxed. So
Yes.
if you take a vein ahead of time and there's some swelling, it can be a problem. The other thing I'll say about the positioning is that this is a good position, supine, head flex, but one of the issues with flexing the head is the jugular venous return. The other thing is that you can see that there's fixed retractors here. Obviously, this is a cadaver, but I prefer to do these in the lateral position with the operative side down. In that position, you have to kind of flex the head to the side a little bit like this to bring it vertex up, but that allows you for the brain to do the retraction itself. And this is sort of the Spetzler's philosophy, Barrow's philosophy, and those who have come from that lineage have that, do their midline approaches that way. Sorry to interrupt.
Okay, so as Dr. Azam said, and as the book also states, that stretch, stretch, and stretch. So it is recommended that you do not coagulate any of those bridging veins which are going across, and even to the point that they may stretch and are about to rupture, but they generally do not, and you just need to make your way through the transcallosal approach. Now, talking about venous infarction, there are one of the ways how such venous infarction can occur. And there are certain important things that need to be careful about. One is, if you take about too many perforators or bridging veins, then that is one of the reasons for complications. The second element is that when you have do a craniotomy and there is injury or slight ooze from the sagittal sinus, extensive use of coagulation over it can lead to a state of thrombosis and can lead to complications post-op. Thirdly, sometimes we reflect the dura medially over the sagittal sinus. Tacking the dura up too tightly in order to gain space here is also one of the reasons that can sometimes lead to thrombosis within the sagittal sinus. So these are one of the few things that you should be careful about. So as I mentioned, a parasagittal craniotomy needs to be done. And this is the diagram that I wanted to share with you. If you can appreciate that if you do a craniotomy bordering the lateral aspect of the sagittal sinus, then you can appreciate that our operating corridor is this. And in order to access the transcallosal space, this is the amount of brain retraction that you need to have. On the contrary, if you do a craniotomy above or on the contralateral side of the superior sagittal sinus, then your operating corridor would be much better. So having discussed the position, incision, craniotomy, dural incision, then we make our way along the transcallosal route. Now, one of the important landmarks is the identification of the corpus callosum, because occasionally this have occurred is that people may mistake callosomarginal arteries for pericallosal, and instead of incising the corpus callosum, they would actually incise the cingulate gyrus, thinking that it is the corpus callosum. So this have occasionally occurred. So you can avoid it by depth percepting, measuring the distance, or better often using image guidance. If you have all those modalities, you will not make that mistake. So having made your position going down to the corpus callosum, ideally make an incision in between the pericallosal arteries. Pushing both arteries to one side, you can also go about it, but for better anatomical orientation, do so in the midline. So as I said, the incision over the corpus callosum should be done, and approximately 2 centimeter in length incision is more than sufficient. And once you incise the corpus callosum, you will enter the lateral ventricle. As you can see in the diagram, once you incise the corpus callosum, you will either enter the right ventricle or the left ventricle. And which ventricle you have entered, you can identify on the basis of the position of the choroid plexus and the location of the thalamostriate vein. But it may be very rare that you may actually enter the septum pellucidum, cavum septum pellucidum. In these circumstances, there will be no anatomical landmarks. So here, you would like to incise the wall so that you may enter the lateral ventricle. So this is after the craniotomy, after the dural incision, after the after opening the corpus callosum, you can see that this is the lateral ventricle. I can say this is the right lateral ventricle because I can appreciate the choroid plexus coursing medially, and then there is this thalamostriate vein coursing medially towards the foramen magnum. So when viewing the inside of the lateral ventricle, you need to retract both medially and laterally. But both elements should be done very carefully. Reason being that sometimes when you're operating upon a patient who has a large lesion obstructing both foramen of Monro, so the midline septum will continue to bulge in your working corridor. This commonly occurs because you have drained the lateral ventricle, the left lateral ventricle has no drainage because the foramen of Monro is obstructed. So in these circumstances, if you simply incise the septum pellucidum, the contralateral ventricle will also drain and you will have good relaxation of the medial side. Similarly, on the lateral aspect, when you're retracting, be very gentle. Use patties, then use retract. Because if you retract too much, if there is significant brain swelling, the genu of corpus callosum is immediately behind it, which you can damage, and the post-operative result would be hemiplegia. So this is the diagram showing that the gene.
Yousuf, just one point about that. You know, this callosotomy that's made is for, you know, just for descriptive purposes only. Nobody makes a callosotomy that long.
Okay.
I put a ruler in that's cut at 1 centimeter, and that's the size of the callosotomy that I make. At the end of the procedure, if you make a 1 centimeter callosotomy, it'll end up being about 1.5 centimeters just as you work and with retraction and things like that. So that's a reasonable length. 2 centimeters, 2.5 centimeters, that's, in my opinion, unreasonable and is too much. The other thing that's critically important, regardless of whether you use navigation, but it's a problem if you end up on the wrong side of the ventricle. You know, that's a big issue. Even if you use image navigation, it can be off by a little bit, and millimeters matter here. The best way of identifying the midline is to look at the little perforating vessels that are coming into the corpus callosum. They usually perforate, and you're going to kind of get a sense of the ones that are coming from the right, the ones that are coming from the left, and that'll give you a sense of midline. And that's one of the best ways to identify it. You can also use the inducum griseum, which is a vestigial gray matter structure that's located in the midline as well. That can be a secondary way of identifying right versus left when making your callosotomy.
Okay. Okay. So having heard those tips about the callosotomy, and once we have good exposure of the lateral ventricle, the next element is to enter the third ventricle. Now, occasionally that we have seen that the foramen of Monro is small. I've also seen quite a lot of cases where there is severe hydrocephalus, but the foramen of Monro is very small. So the next objective is to manipulate through the foramen of Monro to enter the third ventricle. And now there are various ways to do so. One easier element is to give an incision along the column of the fornix. Unilateral fornix injury usually does not produce any neurological deficit, but this is usually discouraged. Reason being that being neurosurgeons, we should not violate the fibers and we should preserve all those fibers. And there are other approaches to this as well. So apart from incising the column of fornix, the other option is to give an incision along the choroidal fissure. This would make a transchoroidal approach. And the third option is to give an incision across the body of fornix to produce an interfornicial approach. Both of these approaches would give access to the roof of the third ventricle. And a fourth possible option stated in certain books is to give an incision along the posterior edge of the foramen of Monro and sacrifice the thalamostriate vein. Now, most of the books state that the thalamostriate vein can be compromised and it is fairly well tolerated. However, the Rhoton states that any vessel in this particular region or the third ventricle should be treated with respect, and none of the vessels, including artery or vein, should be voluntarily sacrificed. So, moving on, this is the foramen of Monro, and this is the opening that we have made along the choroidal fissure. So, this is the transchoroidal approach, but because we are entering the roof of the third ventricle at a slight angle, we can see the internal cerebral vein, which is partly obstructing the vision. This is the interfornicial approach where we have retracted the fornix bilaterally and we have excellent visualization of the roof of the third ventricle. The other anatomical details of the tinea fornicis and tinea thalami have been discussed earlier, and Dr. Azam explained it very well in the previous lecture as well. So this is the diagrammatic representation of removal of a lesion from the foramen of Monro. The basic principles apply that you need to do internal decompression followed by extracapsular dissection. Do not try to manipulate the lesion or pull it through the foramen of Monro, because you will end up damaging or contusing the fornix. Perform internal decompression followed by extracapsular dissection and eventually go about coagulating and removing the stalk. This is again the diagrammatic representation showing that once the septum pellucidum is incised, you can appreciate the right fornix here and the left fornix on the contralateral side. And if you do an interfornicial approach through here, then both the fornix are retracted on sides. You can appreciate the massa intermedia and the roof of the third ventricle. And then you can go about addressing the lesion. So this was about the anterior transcortical approach.
Sorry, can I just say one other thing? Can you go back to your slide where you showed the different ways of entering the third ventricle?
One more.
Two slides. One slide back. One more. Sorry, forward.
No, forward.
This one?
No, forward.
No, go forward.
To the
This
third
one?
ventricle.
Showed the 4 ways of entering into the third.
Okay, sorry.
So as he gets to that slide, I think that the number one here should never be done. Never intentionally sacrifice. I know this is a way that things have been done, and this isn't meant to be no disrespect to the people that have come before us, but unless in this day and age, unless you've done a WADA ahead of time and you know which side the patient's dominant memory is on, this sacrificing of fornix without prior knowledge of which hippocampus is the predominant memory structure is not appropriate. The reason being that if you give a patient a disabling memory deficit, they're done for the rest of their life. You know, we use memory to orient ourselves to our day, how we go about it. It will not work again. It's a very big deal problem to give somebody a memory deficit. So I would suggest never doing one. Now between two and 3, I don't like either, especially 2 where you're doing interfornicial. That puts both fornices at risk again, same issue. And it doesn't, you would never need to do it that way. 3 is reasonable, but I much prefer doing it on the thalamic side, on the opposite side. So one that's not shown here is if you reflect the choroid plexus the other way, you can open the tinea thalami. And what that does for you, and usually you don't need to take the thalamostriate vein. It depends a little bit on the location of the pathology, but usually you don't need to do that. You can just make your opening in the tinea thalami posterior to thalamostriate vein, or for anterior third ventricular pathologies, you can pick the side. There's usually an asymmetry with where the internal cerebral vein bifurcates, one side versus the other. And if you can tailor the side that you approach it from based on that bifurcation, and then you can extend the foramen of Monro further posteriorly on whatever side where the bifurcation is further posterior, if that makes sense.
Okay. Sorry, Azam, are you a co-host as well? Is Azam a co-host? Imad?
Yes, sir. He's a co-host.
Azam, can you show us exactly where you'd give that incision?
Sure. How do I make my cursor visible?
Can we get Azam's cursor visible, Imad? Maybe Yousuf, you may help Azam and take the cursor where he wants. Yeah.
Over here?
Yeah, so no, posterior. So along see how where 3 is, but if you were to reflect the choroid plexus the opposite direction, you could make it, but yeah, with the choroid plexus reflected to the opposite side. So in diagram C, if you look at diagram C, they show the tinea choroidea here. They have it labeled. They show the opposite side, the thalamic side is the one where you could make your opening for a thalamic approach.
Okay.
Okay, brilliant. Thank you.
So this was a little overview about the anterior transcallosal approach. Then we talk about the anterior transcortical approach. This is usually different in terms of access to the lateral ventricle and is commonly done only if you have ventriculomegaly or dilated ventricles. Working in narrow ventricles may also be possible if you have image guidance, but it would just make it very difficult and time consuming. With a transcortical approach, you can address the lesions of the ipsilateral lateral ventricle, third ventricle, but going on to the frontal horn of the contralateral ventricle would be difficult. So the skin incision and craniotomy is again tailored generally over the middle frontal gyrus, usually on the non-dominant side. But if you are operating on a patient on the dominant side, then you need to be very cautious. The inferior frontal gyrus should not be violated because it will cause problems with the speech. Hence, central craniotomy over the middle frontal gyrus, perform a small corticotomy, and then through the cortex enter the lateral ventricle. Once you enter the lateral ventricle, the further identification of structures is more or less the same as that of a transcallosal approach. You will see the anatomy of the lateral ventricle, then you can either go transchoroidal, interfornicial, or whatever the approach that you deem appropriate. Then there is an anterior frontal approach. This is generally reserved for lesions which are confined to the anterior inferior aspect of the frontal horn of the lateral ventricle and the adjacent part of the third ventricle. So predominantly it is used for lesions which are at the base of the frontal horn of the lateral ventricle. And what you do is you do a completely supine position. The craniotomy is generally above the eyebrow. The lower border of the craniotomy should border the supraorbital margin, and medially, as I mentioned again, it should extend over the superior sagittal sinus so that the dura can be reflected across it. This will usually open the frontal air sinuses, so be sure to wax it well. Once you have done the craniotomy, you need to elevate the frontal lobe. That is, you need to elevate the orbital surface of the frontal lobe. Once you do that, you will identify the arachnoid covering the chasm. Incise the arachnoid, drain some CSF gradually, and you will gradually achieve much more brain relaxation and easy retraction. Then you can also identify the supraclinoid portion of ICA and its bifurcation into the AC and MCA. Once you have done that, you retract the frontal lobe medially. So this is the box, and this is the frontal lobe being retracted medially. Once you do that, you will identify the lamina terminalis, and you open it, and you will enter the lateral ventricle and a part of third ventricle. So again, in this approach, you can identify the lesion, use the general measures of tumor resection, that is internal decompression, followed by extracapsular dissection. Do not violate any vessels or fornix in this approach, and you will be done with the procedure. So having discussed the anterior approaches, then we have certain posterior approaches.
Sorry, Yousuf, let's just get comments both from Azam and Hasan on this, please.
Okay.
Yeah, so I think one of the key things with the anterior versus posterior transcallosal approach is that the positioning is really critical in these cases. So for anterior, you need to have the head well extended, no matter whether you're doing it in the supine position or in a lateral position. And that gives you that appropriate access to that corridor. Oftentimes the interhemispheric dissection in the anterior part is a little more difficult because the frontal lobes tend to be a little more stuck together, but it's definitely doable and is not that difficult. Posterior interhemispheric, interestingly, there's very few bridging veins posteriorly. We'll talk about that. I'm sure you'll talk about that in a second. The other thing I'll mention about anterior interhemispheric, for pericallosal aneurysm, which is a common location for aneurysm, this is a very good approach for that as well, and it's provides excellent access that way. The last thing is craniopharyngiomas. I know that this is a ventricular talk, but craniopharyngiomas often extend into the third ventricle. And this, depending on how far anterior the craniopharyngioma extends, oftentimes an endonasal approach may not be ideal or needs to be combined with one of the anterior interhemispheric approaches to get a better access to a lobule that may be extending anteriorly. So that is a great approach for that.
Hasan, any comments?
Well, just going back, I just wanted to kind of emphasize what Azam was saying in terms of positioning for the interhemispheric transcallosal approach. I've done it both ways, as you described in your image, as well as what Azam said with the ipsilateral side down. One of the things that I thought was very helpful that I learned from, just watching videos from Aaron Cohen-Goodall is using cotton balls as retractors instead of, those fixed retractors. That can be very helpful as well. And then in terms of the veins, as Azam was saying, I haven't had to take the thalamostriate vein. I think I would avoid doing that. The anterior septal vein, I have taken, which you can. I think you may have mentioned that. I've done that particularly for colloid cysts. And then, sometimes these approaches can be done endoscopically. And you mentioned in one of your images, the massa intermediate interthalamic adhesion is also present. And I have gone through the interthalamic adhesion or cut it in order to get a more posterior approach or direction, especially for pineal lesions. So that's something that can be done as well.
And one of the interesting things I think about the anterior transcallosal approach is that oftentimes based on the trajectory that you need to get into the third ventricle, for instance, for germinoma biopsy and things like that, you often need a very, very anterior trajectory in order to get to lesions that are posterior if you're going transforaminal, meaning through the foramen of Monroe, because you need that very low trajectory. Even though it's longer, it works well for endoscopically. You can also do it for open surgery, but it's not quite as the length of the trajectory tends to be quite long. The other thing is that I don't think that in this day and age doing a transcortical open approach is reasonable, unless the pathology extends a fair bit into the cortex or into the corona radiata. Perhaps then it would be reasonable. The only caveat to that is that there's some of the different brain speculums like brain path or Vicor or other things like that you can use. But if you just make a corticectomy, the length of that trajectory through the brain, I think, is unreasonable. And it ends up being that you get a lot of brain pooching in there and you end up resecting a lot of brain in the process. So really try to learn the midline interhemispheric approach well. People are often afraid of the blood vessels, but I can assure you that it's not as difficult as you think. You just have to take your time and you'll be happy with the results.
Okay, so having gone through the brief overview of the anterior approaches, we'll be now touching the posterior transcortical, transcallosal, occipital, and posterior approaches. These are generally indicated for the atrial lesions, that is in the atrial part of the lateral ventricles, or when you want to access the quadrigeminal cistern or the posterior part of the third ventricle. So talking about the posterior transcortical approach first, the position, again, generally you would like to position the patient lateral, that is lateral 3/4, and slight neck flexion. And for a posterior transcortical approach, your craniotomy should be tailored over the superior parietal lobule. You should spare the postfrontal gyrus in order to avoid any injury to the somatosensory cortex. The parieto-occipital sulcus and the parieto-temporal sulcus should also not be violated, particularly on the dominant side. Reason being that there are visual fibers going along and there are reading fibers which can produce dyslexia. And once you have done the craniotomy, the dural incision is generally given along the long axis. And following that, you enter the atrium of the lateral ventricle. Once you enter the atrium of the lateral ventricle, this is the diagrammatic representation that how you enter the atrium of the lateral ventricle. The position, as I mentioned, is 3/4, that is head turned down approximately 3/4, so that your entrance to the towards the lateral ventricle is relatively isn't up a bit. So once you enter the lateral ventricle, these are the structures that you will identify. If the lesion is within the lateral ventricle, you will remove it easily within the atrium. But if you need to manipulate and enter the third ventricle, then you need to go by one of the three approaches. The first approach should be either along the choroidal fissure, that is the transchoroidal approach. The second option is along the crux of the fornix, or the third option is when you go medially along the cortex. So if you do a transchoroidal approach, this is the access that you will have towards the ambient cistern or cortigeminal cistern, and you can appreciate that this is the internal cerebral vein, and these are the posterior cerebral artery, and the working window is pretty small. So if you are using this approach, generally conserve it for the lesions which are confined to the atrium of the lateral ventricle. If you want to use it for a lesion that is going into the third ventricle or is involving the cortigeminal plate, or you are accessing a large cranial tumor, a cerebral approach would be adequate, because this usually provides a very small working window with extensive blood vessels surrounding the lesion, and confine it to the lesions confined to the atrial of the lateral ventricle. Again, same diagram showing a transchoroidal approach to the atrium of the lateral ventricle, and then you will access the cortigeminal cistern with extensive veins and vessels and a narrow working corridor. You should be very cautious when applying retractors, because all the structures are very important. The retraction applied on the visual cortex, underlying cortex, can cause visual problems. Retraction of the pulvinar should also be kept minimum, because it can cause speech disturbance, particularly in the dominant hemisphere. And as I mentioned, that these are generally used for the atrial lesion. Then if you go back to the posterior transcallosal approach, this is again indicated for accessing the atrial lesions of the atrial ventricle. The position is same, that is lateral 3/4. The craniotomy is based across the superior sagittal sinus. You do the craniotomy and you retract the brain. Generally, the site of the lesion is the one that is down, so that it will provide brain relaxation. You can appreciate the forks up, the brain retracted downwards. Now, if you need to enter the atria of the lateral ventricle, you need to incise the cingulate gyrus, because within the splenium of the corpus callosum, it is in the midline, and then you will enter the third ventricle. So in order to enter the lateral ventricle, you need to incise the cingulate gyrus. Incise the cingulate gyrus and you enter the lateral ventricle. Within the lateral ventricle, you can perform the lesion resection, whatever the lesion is. And if you want to access the cortigeminal cistern or go back posteriorly, you need to give an incision over the splenium of corpus callosum. Although the window is not very good, but again, both these approaches are recommended mostly for lesions within the lateral ventricle. Then we have a similarly sized occipital approach, which is again done, either you do a complete occipital position.
Sorry, Yousuf. I think after every technique, just get input from our eminent host here. Azam and Chandra is there as well. Chandra, I don't know if he's heard this. Hasan, any comments, please?
Yeah, so you mentioned the supraparietal approach to the atrial lesions. Oftentimes these lesions or these corridors can be very long, and so it's also important to keep that in mind. And you can use adjunct types of technology like your stealth or brain lab neuronavigation, and I oftentimes use ultrasound as well to make sure that I'm at the right trajectory. So that's just a point to make as well.
Hi, Salman.
Yeah, for the posterior interhemispheric. Oh, go ahead. Sorry.
How are you, Professor Deopujari? Good to have you.
I'm good. I'm sorry, I got a little delayed. There's another activity happening locally.
Sure.
Basically, I think though I joined late, I would just like to mention that apart from the fact that we need to be correct in our approach, I look at it from one other point of view. The most common lesions which are tackled by this kind of approach are either the meningiomas, which are again common in the atrium for some reason, or the choroid plexus papillomas in children. And in both the conditions, one of the important considerations is the bleeding. So I think looking at a MR very carefully is important. Sometimes we even do an MR angio to see if you can see where is the vascular pedicle. And my attempt usually is to go a little low than what is usually described. I would probably go in the parieto-occipital sulcus rather than going or a little further, to make sure of the fact that you are able to get hold of the pedicle early enough in your, I mean, some of them tumors may be large and you may have to decompress, but early control of the pedicle becomes also important, and that may be something to look at preoperatively at image as well as initially when you are making the approach.
Yes, Azam.
Yeah, I was just going to say that the posterior interhemispheric tends to be quite straightforward as far as the initial approach is concerned, because interestingly, there tend not to be bridging veins there. And that can make it easier for you to make the approach. Once you're there, this is one of the areas where it's really important to understand where you're trying to get to and what the different windows provide you based on where you make your choroidal dissection, whether you make it on the forniceal side, or the fimbria, on the side of the fimbria, or you make it on the side of the pulvinar. If you have your option, you can even go through pulvinar. Pulvinar is one of the safe entry zones to the thalamus. It's very, very well tolerated. Pulvinar tumors have very low morbidity if you take those out. So I would always try to go on the side of the thalamus, even in this posterior location whenever possible. Now, the caveat being it depends a little bit on the location of the pathology and where you need to get to.
Okay, Yousuf.
Yes. Okay, so we talked briefly about the posterior transcortical, transcallosal approach, and now we have the posterior occipital approach. Now it is again a bit more posterior to the posterior transcallosal approach. The craniotomy is centered over the sagittal sinus and the transverse sinus. Again, you should ideally go across the sagittal sinus or above the transverse sinus. So this is how the craniotomy would look like. The position should again be lateral 3/4, and you should incise the dura in a diagonal fashion so that you can reflect it in the form of a triangle across the sagittal sinus and across the transverse sinus. Once you do that, you retract the brain downwards, that is away from the midline. You can see this is the fox. This is the internal occipital vein. Rhoton suggests that if you need to coagulate the internal occipital vein, do so. Otherwise, as he states, that protect all vessels, and voluntary, these veins should not be compromised. Posteriorly, you can appreciate the crux of the cingulate gyrus. If the same cingulate gyrus was incised anteriorly somewhere here, then this would have made it a posterior transcortical approach. But now, since we are incising it in the crux of the cingulate gyrus, this would make it an occipital approach. So you give an incision over the cingulate gyrus and you enter the occipital horn of the lateral ventricle. If you need to access the part of the third ventricle, then you need to incise the fox here. The fox running along the straight sinus that you can see. So you need to incise the fox here so that you can along the straight sinus, so that the occipital horn of the lateral ventricle and the third ventricle can be accessed simultaneously. But generally reserve it for the lesions confined to the occipital horn of lateral ventricle. So another approach that I'm going to talk about is the infratentorial supracerebellar approach. This is one of the ideal approaches for the large tumors located on the quadrigeminal plate, quadrigeminal cisterns, and of the pinion region. Now, one of the important elements is to identify those patients, particularly those who have very shallow posterior fossa, because your approach is going to be beneath the tentorium. If the posterior fossa is very shallow, then your approach is going to be very difficult. Other than that, if the posterior fossa is not shallow, then a good prone positioning and flexion of the neck is adequate. I have also seen that many neurosurgeons prefer doing this approach in sitting position. Although there are certain centers where sitting position is not routinely performed, but in certain centers, sitting position is routinely performed with minimal to no complications, provided that you have adequate padding of the body, decompression boots, and a central line to aspirate for possible air embolism. So sitting position is usually considered as an ideal site for approaching these tumors, because this will give you good orientation of the anatomical structures. So In this kind of approach, your craniotomy has to be tailored like this. It has to be posteriorly, should cover a part of the sagittal sinus. Laterally, this should be around minimum of around 3 centimeter covering transverse sinus, and inferiorly should extend up or 1 centimeter or so above the foramen magnum. This part of the craniotomy is a bit difficult because you are going to traverse 4 sinuses, so make sure that you do not damage any of the sinuses during craniotomy. Once you have removed this part of the bone, then you need to give a dural incision. The dural incision is given in a C-shaped structure from here to here, then from here to here. The occipital sinus is then tied between the two, and the entire flap, this V-shaped flap, is reflected up. So now you can appreciate that there's a posterior fossa, and then you need to grow across the space between the tentorium and the cerebellum. So this is the corridor that you're going to approach. The superior Vermian vein, also known as the precentral cerebellar vein, is one of the few veins that will come directly in the midline of approach to pineal tumors. This is that vein. So this is the vein that the Rhoton suggests to take it, because this has no clinical significance and it will interfere with your surgical approach or removal of the tumor. So approach through here, and taking this vein is recommended. So before I briefly discover the lateral approaches, Dr. Azam and Dr. Hasan, your comments over the this particular approach?
So I think the sitting position is great. It's not that difficult. You need to do a little rehearsal ahead of time to make sure that you can get your pins and everything in the right position. But what it provides you, in my opinion, is really, really great brain relaxation. You can't compare it to a prone position. Even if you concord the patient and put the head of bed very severely elevated, you can't even come close to that, to what you can achieve in a sitting position. I know that in the textbooks, they say to put in a central line. Aspirating air through a central line, I don't know if anybody, you can query all your professors. I've not heard of a single person say they've been successful doing that. We don't do it at all. We do listen with the precordial Doppler to hear if there is air embolism. But I think the key there is to prevent the air embolism in the first place, to be very diligent along your work along the sinuses to make sure that you don't entrain air while you're doing that. But it's really a great approach. The precentral cerebellar vein, similarly to the veins in the anterior third of superior sagittal sinus, you can take it. But if you truly need a true midline approach, then that's fine. Oftentimes, a slightly paramedian approach, preserving that is also possible, but you should be very careful about retraction on that vein. So as you work, we're focused on the right in the center of our operation. We tend we lose track of the veins that may be put on tension. If this vein is avulsed from the confluence of Galen, it's a problem. That is a very, very big deal problem. So before that happens, and if it seems like it's on a fair bit of tension, better to take it than not. But many times you're able to avoid taking it by working slightly paramedian if your pathology allows that.
Okay.
I completely agree. I think you can really perform a unilateral approach or going on either side of the vein and preserve the vein many a times. And these days you can actually make a procedure endoscope assisted and rather than widening the corridor.
Okay, so finally we have the lateral approaches. These include the terional and the subtemporal and temporal approaches. Now, we have covered the anterior, we have briefly touched the anterior, posterior approaches. The temporal approaches are again indicated for lesions which are, which are indicated for lesions which are confined to the temporal horn of the lateral ventricle. You need to tailor your craniotomy, which is usually over the temporal lobe, immediately above the pinna. If the lesion is small, you can also use use a linear skin incision, or you can use a horseshoe-shaped skin incision, or you can use a U-shaped skin incision, whatever is easy for you. So then access can be done via the middle temporal gyrus or inferior temporal gyrus. I usually, most of the books state that a subtemporal approach through the inferior temporal gyrus is relatively preferred. Reason being that within the middle temporal gyrus, you run the risk of damaging some of the optic radiations, and this would subsequently lead to homologias. Therefore, it is better that you do dissection in the inferior temporal gyrus. So once you enter the inferior temporal gyrus, you will enter the lateral ventricle. You will enter the lateral ventricle, the temporal horn. Subsequent lesions can be identified, excised. You can also appreciate that the choroid plexus, which is retracted to show the ambient cistern beyond it. And then there is also the posterior cerebral artery. And lesions towards the ambient cistern can also be accessed, but yet again, the corridor is very narrow. Hence, use it to lesions which are confined to the lateral ventricle and not going beyond. And that's probably it regarding the basic outline of approaches to the lateral ventricles. And since we had already discussed a lot of anatomy in the prior lecture, I did not reincorporate everything so that it would be too much repetitive. Your comments, sir?
That was a very, very nice presentation. I think for this last bit, the temporal approach, the positioning again is really critical. You need this approach, not straight across, but you need, my virtual background is getting in the way, but you need kind of like an inferior to superior angling approach that's going upward. What that requires you to do is put the head with the vertex parallel to the floor, but the vertex down. And vertex down is really key. So that gives you a comfortable angle from that's an ascending angle towards the ventricle, which I think is very important. And I agree with inferior temporal or subtemporal. I prefer subtemporal. Depending on the pathology, it's usually achievable. The real critical thing when you do subtemporal is vena labae. So vena labae, and you cannot really get a great understanding of the vein of labae and where it's attached or where it enters into the sinus based on the preoperative imaging in most cases. The reason being that it can course within the tentorium over a relatively long distance. And so it's really important at the time of surgery to spend some time to identify labae after the brain is relaxed, and then see how much of labae you can release from the tentorium. If it appears that the vein of labae is coursing through the tentorium over a longer distance, meaning that your corridor subtemporally is going to be very narrow, better to leave it alone and go through inferior temporal gyrus. The only caveat there is that if you're going to resect a lot of the temporal lobe, then oftentimes you can take labae. But please listen to what I said carefully. I'm not advocating taking labae, okay? Only if you do an extensive temporal lobectomy is taking vein of labae reasonable. So in the vast majority of cases, you should not take the vein of labae. It will result in swelling and lots of problems. Better to go through the inferior temporal gyrus and preserve vein of labae if that's the issue. The other thing I'll mention is that oftentimes this approach is used to get to the hippocampus. And I'll speak for myself that when I was studying this anatomy, the anatomy of temporal lobe, there's a reason why Rhoton has a specific volume on temporal lobe. And that is because the anatomy is complex. The relationships are difficult to understand. And so it takes time to really delve through that, the difference between hippocampal sulcus and the choroidal fissure, and being able to identify these in this lateral position is really, really critical when you're studying this anatomy. So this is often a place where if you get a little bit lost, it results in significant morbidity for the patient. Other places you can sort of sort things out while you're there and say, okay, well, this is related to that, that's related to this. In the medial temporal lobe, it's much, much more difficult in my experience to gain that knowledge. And so really spending time ahead of time to think about these, the different structures, how they're going to look as they're partially resected is really important.
And they also say that the hippocampal injuries produce the maximum memory deficits or the maximum neurological deficit. So you should be cautious about it.
That's right. If you're going into the hippocampus, unless it's severely diseased, you should have some form of memory assessment, whether that be a WADA test, which is what I prefer, because even though we have functional MRI and we use functional MRI for memory, if you give somebody a memory deficit, a short-term memory problem, that patient will be disabled and they'll come back to you and you'll remember. You'll not forget that patient. So otherwise, a WADA test is very easy, very straightforward for somebody with endovascular skills to do, and I think is a prerequisite if you plan to go through the hippocampus, or if the hippocampus is only minorly involved with the pathology.
Do you use a propofol WADA test or do you use tribendol?
I'm sorry, can you repeat that?
Do you use a barbiturate or propofol for WADA
We use
test?
sodium amytal.
Okay. So I don't know about Pakistan. The amytal is not available in India. So we do a modified kind of a thing with the propofol test.
I see.
The other thing which is quite important is probably to have a proper neuropsych. I think one of the things which was being talked about temporal horn. So when do you need to actually reach temporal horn primarily to get at a lesion? I think the most common reason probably is to do a medial temporal hippocampectomy surgery. And I think therefore, yes, this preoperative testing becomes very, very important. And of course, as you told, the importance of the choroidal fissure becomes very, very important. Because that can, if you take an intra ventricular approach, then it is much easier to save the vein of Labe rather than if you are operating mainly on a parenchymal pathology. Yes, if you want to get into the tentorial hiatus, then of course the subtemporal approach has to be the better and the more preferable approach.
Okay, we have Adrian. He's our friend from Puerto Rico. He's going to be saying a few words, a comment. Yes?
Yes, I would just like to add on the comment that that Shekhar has made, that more than 15 years ago, we standardized the WADA test using propofol, even in children. So it works exactly the same as sodium amytal. So for most of the countries who do not have amytal, it's a very worthwhile test, and you get a lot of interesting data, especially if you're doing epilepsy surgery. That's just my comment.
What time is it there now?
6 a.m.
Oh, good for you, man. Excellent. Good to see you.
There were a few questions about the thalamo-striate vein, whether or not this can be taken or not. As Hasan said, that you prefer not to take it. I have taken it on occasion in certain situations. It's worked okay for me, but I'm not telling you to take it routinely or that it can be taken. Sometimes the circumstances force your hand, and in those unintended situations, I have taken it, but I never went in with a thought a priori of intentionally sacrificing thalamo-striate vein.
Any more questions?
Yeah, there's another question. Anterior transcallosal approach, if we enter from the interfornicial or transchoroidal corridor, as these corridors are posterior to foramen of Monro, so can we go to the lesions anterior to foramen of Monro? So yeah, the question here, first of all, the transchoroidal is not descriptive enough. So you can go transchoroidal on the fornicial side, or you can go transchoroidal on the thalamic side. Either way is a form of transchoroidal. It's a tinea fornicis or the tinea thalami on whichever side that you go on. And so it's a minor point, but you can do a transchoroidal via either route. And it's only that approach to get to the third ventricle is only only makes sense if you're posterior to foramen Monroe, because there's no tinea fornicis or tinea thalami anterior to foramen Monroe. So pathologies that are in the anterior third of the third ventricle, you can do through the foramen Monroe by extending the opening through the foramen Monroe, transforaminal. I don't, a lot of textbooks, and this is again, no disrespect to the people that have come before us, but technology evolves, our understanding evolves, but putting your bipolars in and spreading the foramen Monroe, in my opinion, is not a reasonable approach, because that's just a way of injuring the fornix. It's not to be done. What you should do is be very intentional about where you make your opening in the foramen Monroe. And as I already mentioned, if you look at the bifurcation of the venous anatomy from the internal cerebral to septal and thalamostriate, you can select your side based on where that bifurcation is further posterior. It's a small nuance, but it's very, very important. Pathologies anterior to the foramen Monroe can usually be approached through the foramen Monroe in the third ventricle. Alternatively, as Yousuf mentioned, you can use the anterior interhemispheric approach to get that very low sort of transbasal approach if you need that to very, very anterior pathologies. I think the classic example is a craniopharyngioma that extends into the anterior third ventricle. That would be the example of where that approach is most widely utilized. Any comments from others?
I entirely agree with you.
Totally agree. Chandra, you wanted to show some cases?
Not really. I mean, one could show cases, but I think this discussion is pretty stimulating. So I think we can carry on. Have they finished complete?
Yousuf has finished his talk. Yes.
Yes, I have done.
So he showed anterior, posterior, temporal, all approaches. So
yeah.
What about endoscopy? I'd first go with Chandra and then come back to Azam on this. So, what about endoscopy and all these procedures, and how can we improve all what we're doing at the moment?
I think the biggest change in my practice after endoscopy has been the fact that whenever we are in doubt, one can take a biopsy and do a third ventriculostomy or a septostomy as necessary. So for immediate solving the problem of CSF circulation, and to know what is probably a better thing to do, if you're not sure what kind of a tumor it is, if I know if it is a pilocytic astrocytoma, I would go for a more radical excision, and it gives me a little more time to prepare for it. If it is a small enough tumor, anything like 2.5 centimeters tumor, not very vascular, you could even remove it endoscopically, or if it is a cystic lesion. But I think for larger tumors, I have mainly used it as a CSF diversion procedure in emergency and getting a biopsy so that I know what is in store for me when I'm going to do this. I do a lot of actually endoscope assisted surgery. I use endoscope very, very regularly in ventricles at various stages in the procedure. Apart from taking biopsy and CSF diversion, I would like to make sure that there is perfect hemostasis at the end of the procedure, that I have been able to get the lesion out completely. And in some cases, like a large intraventricular extension of a craniopharyngioma, I use it to decompress and then plan a radical surgery later on. So use it for various purposes. And I think in that sense, it has been a very good thing. I mean, if I have to give a blanket statement that it has sort of helped a lot of tumor surgery, I would say in various other forms. I wouldn't say for complete excision, I am sold out to using endoscopy, no. I think it still remains mainly microsurgical procedures for all the large solid tumors, and endoscopic assistance certainly helps in them.
Hasan, you probably have some ideas on this topic.
Yeah, no, I certainly agree, with everything that's been said. I think the endoscope definitely has its advantages. And, I've used it for various types of cases, call it cyst resections, biopsies, and things like that. Resecting large tumors endoscopically just by itself, obviously very difficult just because of the field of view and the blood, as you know, compared from a microscopic view and an endoscopic view, if blood, gets into the ventricle, into the CSF, then it's very difficult to visualize things. Some people do describe actually placing an endoscope and draining all the CSF, from the ventricles in order to, avoid the visualization issues. But again, I think this comes with a lot of experience and practice. And so I think John Lee and Walter Jean in the past have mentioned in these talks that when you're starting out doing endoscopic work, it's nice to have both options, microscopic and the endoscope present. And, as you do these cases, having both options is important, and then transitioning to one or the other as you learn different techniques is a way to do it.
Yeah, these are all really great comments, I think. I use these approaches, I think, in a few scenarios, like Hasan mentioned, for colloid cysts. I think it's a very endoscopic approach is very nice because these cysts tend not to be very vascular. So I think that's the key thing. Size and vascularity are the two key factors that may limit an endoscopic approach. It's a great way of biopsying lesions, posterior third ventricular tumors. There's a wide differential. Many of those can be treated with radiation, chemotherapy, things that where surgery is not necessarily required. So biopsy, it's really great. Resection is really dependent on size and vascularity. So if it's the larger the tumor is, the more vascular the tumor is, the less likely a endoscopic approach is going to be fruitful. Anything is possible, sure. Is it possible to do it? Sure, it's possible to do it, but it's the economy of time. The more time you spend in the OR, and the more frustrating it can be. One of the points that Hasan mentioned that's not to be missed is that if you get into bleeding and you are trying to stop it, you don't know what's going on because there's just so much blood. It's usually not that there's really truly like a catastrophic hemorrhage going on. It's just that you can't see because there's too much blood. This scenario of draining all the fluid from the ventricle is very, very helpful in stopping and allowing for hemostasis. Allows your bipolars or monopolar to work better as well. And so that is another approach that you can use. The other key thing about ventricular surgery is seizure risk. So it's really important that these patients be pre-medicated to avoid seizure. If we're going beyond 30 minutes, we actually load the patient with fosphenytoin. We may not continue it post-operatively, but we will load with fosphenytoin because of the, who knows the exact etiology of why it results in seizures, but this ventricular washout syndrome is prone to causing seizures. So I would recommend that you do that. We also do it with continuous EEG monitoring in those situations as well for that very reason. But I think as technology evolves, we'll probably do more and more. As Dr. Deopujari mentioned, that the endoscope assisted is a really great approach, particularly for supracerebellar, infratentorial or transtentorial. It can make it so that you don't need to make as wide of a craniotomy. The angles that you can see are much wider. There is a bit of a learning, a bit of a steep learning trajectory for that, especially if you're only using 2D endoscopes. If you use 3D endoscopes, it may be a little bit easier to acquire the skills. Done it both ways. I'm not sure which one's better yet, but if you have the ability to do 3D at first, it might be nice to try it that way. Any other comments about endoscope?
I think we have a question.
Salman Bhai, what do you think? What's been your experience with endoscope assistance?
I think really with endoscope, I feel that things have evolved dramatically. I think we have it's a huge instrument that you have in your hand, and if you use it in the right way with the help of image guidance and do minimally invasive. So all those old days that used to have big craniotomies and retract huge and cause venous infarct and all that, once you do endoscopic approach, and if you have proper instruments and training, is probably the future. I think we have had some sessions here. Pepe has shown here, Joachim showed here that, the way Cabatron is used now in the endoscope and able to take out big tumors as well, and how hemostasis is done and secured. So all that is now possible, which wasn't possible beforehand. And it's just, if you have the right equipment, you have the right gadgets, and you have the right training, and you have good anesthetists need to be there as well along with that, and a little bit of brain on the head. So if you have that, I think you can do good things to patients. We have a question here from Domenico, and I'll get him in here and see what he has to say. Yes, Domenico.
Good evening. Congratulations.
Sorry, where are you from?
I'm Domenico Catapano from Italy. Congratulations to Professor Salman Sharif for those webinars. I have some questions about the transcallosal approach, interhemispheric transcallosal approach. A question to the faculty. What about a transverse incision inside the longitudinal incision in order to avoid disconnection syndrome?
So the fibers of the corpus callosum, you can do that. The issue is that you have to be able to work through a very, very narrow corridor if you make a transverse incision. Usually the minimum that I've been able to do is 1 cm, 1 centimeter callosotomy. You can, if you make a transverse incision, what you're saying is that you can work through perhaps even a narrow corridor. I'm not saying that it's not possible. That is something the smallest I've been able to work through is about 1 centimeter to be able to get my bipolar in and suction in and be able to have some facility of movement. If you have a pathology right on the other side of the corpus callosum, I suppose that may be feasible to do it that way. But as you work, even if you were to make it a transverse in the coronal plane incision, what will happen is that as you work, it'll widen itself, and you'll probably end up around 1.5 centimeters in any event in the AP dimension. So I think regardless of which way you make your opening in the corpus callosum, I probably end up with something similar to that. With disconnection syndrome, you need to make usually a much longer incision in the corpus callosum, something on the order of 2.5 centimeters to start having some issues with that. I've not had an issue with making 1 or 1.5 centimeter callosotomy and having a disconnection syndrome.
I also wonder as to what kind of a exposure you are going to get if you are going to retract anteroposteriorly rather than retracting from side to side. I think whatever incision you make in the corpus callosum, you are going to retract from side to side to get a proper orientation into the ventricle. Unless you know the pathology and it is lying right under your incision, which can sometimes, I mean, you can be lucky or navigation can give you that kind of precision. But usually you like to know your orientation well, and you like to see the ventricle in an AP orientation. So I think for the usual orientation we have of the ventricular anatomy, to be able to confidently remove something without damaging the nerves, the veins and the other structures, I think it may be possible, but I can't think about using it as a corridor.
Okay, we have Nafis Ahmed Khan who wants to ask a question, so I'll just unmute him. Nafis, go on.
Yes, sir. Sir, I just want to ask your comments about the endoscopic versus open approaches for the colloid cysts.
Dr. Azam will answer.
I think that the both can be done well. There's a lot of people that are dogmatic about it, that this should only be done this way or should only be done that way. And I think that trying to get into a debate about which one is superior, I think is not useful. Suffice it to say, there's large series that have been published that demonstrate that it can be done either way, it can be done well either way. I think more important questions are the side of the approach and what the goals of the resection are. In my opinion, it's always great to get that gross total resection and take the entire thing out in one piece. For colloid cysts, I don't think that that's a good approach. You know, almost the best approach is to evacuate the contents of the colloid cyst first and then slowly peel the wall off, working posterior to anterior. Anterior is where the most of the risk comes in because that's where it's attached to the columns of the fornix. And you have to take care not to neglect the opposite side. It can often be attached to the contralateral undersurface of the fornix. So you can end up with a bilateral injury quite easily in these surgeries if you're not paying attention, because you injure the ipsilateral fornix a little bit because of the dissection that you can see. And then because of retraction and other factors, you end up injuring the opposite side of the fornix as well. So I think that it can be done well either which way. I prefer to do these personally endoscopically for the majority of cases, unless they're very, very large. But the contents can be evacuated very easily with endoscopic techniques, and you can peel the cyst off using endoscopic techniques as well. That's my go-to personally, but I don't think that it's wrong to do it open either.
I have a little reservation if the ventricles are not too large, if the cyst actually turns dark on T2 weighted images, meaning that I may not be able to empty it well, it may have thick contents. These are the two conditions where I am reluctant to depend on endoscope, and I am prepared to use microscopic dissection in these cases.
Okay, Hasan wants to show a colloid cyst video, so if you want to share. You need to unmute yourself, Hasan.
Sorry about that. I know there were some questions about the colloid cyst, so I figured I had this case that I presented a little earlier that I would just show as well as a video. But this was a 38-year-old man with a headache who came in to our ER, and you can see this large colloid cyst. And when I was thinking about doing this case, I initially had thought about doing this open. But my experience with endoscopic work really in training was, we didn't have some of the equipment that we have here at the University of Virginia. And so I figured I would prepare for both, try to do it endoscopically. But as I said, when you're in current situations, sometimes you have to do it open. But so I'll just go, through these are the advantages, disadvantages of doing it open and the techniques and endoscopic. But Azam mentioned how he does these colloid cysts endoscopically as well. You can see here that an EVD was placed in an outside hospital, at Coker's Point, and typically, I've done these cases through Coker's Point as well. But what I found was that sometimes these colloid cysts, their attachment, especially to blood vessels, are more posterior, into the foramen of Monroe and the third ventricle. And so this more anterior trajectory sort of on the forehead can be useful as well. And the other thing I ended up using was the Nico cutter aspirator that I think we've mentioned before. But this is just a short video of it. As you enter the ventricle, you can see the cyst. You can see around the cyst, and including the aqueduct. And so really, as Azam mentioned, it's a matter of sort of dissecting the cyst wall and decompressing the cyst. So you can see we're putting in these forceps, using the cutter aspirator to aspirate all the colloid cyst content, and then using the bipolar electrocautery to shrink the cyst wall and dissect it off the foramen. You can see, though, the fornix is bruised, and that is something to try to avoid. But you use those steps sequentially and try to dissect this off the wall. And in this video, you'll start seeing that there are blood vessels now with attachments sort of posteriorly. And so I'll just forward this for the sake of time. So you can see these vessels now that we try to dissect and bipolar to avoid the bleeding that occurs. Inevitably, you know, all the colloid cysts that I've done endoscopically, there is some bleeding that does occur. And so you have to be very patient with that. And so once the cyst is dissected, you can sort of you know, pick it up with the graspers and remove it. And then you can see that, you know, there is some bleeding, but you have to stay calm, irrigate, try to find an area that you can identify that's the wall, and take care of the bleeding. You can see the aqueduct, and obviously, you know, you want to do a septostomy as well, and so you can see that to the contralateral side. So this is, you know, post-op scans. The incision here, you know, blends in very well, even if you have to do it on the forehead. But this is sort of how I'm doing colloid cysts now in terms of the trajectory.
That's a very nice case.
Nice demonstration.
Okay, Yousuf, have you got some MCQs to show?
Yes, Imad have it. Imad, can you share, please?
Maybe I can show a small tumor if there is time.
Sure, we can. Imad, are you there? Is Imad there at all? I think, Deopujari, you could show your thing. I don't know where Imad is.
Yes, sir. Sorry.
Imad, you sleeping?
No, sir.
Can you show us the MCQs, please?
Yes, sir.
Share with us. No. Go back. Questions first. Okay, these are the questions. All right.
Yes.
What's happening? That's better. Okay, Yousuf, you want to take it away?
Sure, sir. Wait a minute.
Can you see it, Yousuf?
It's very blurry for me somehow. Can you read it if you have it very clear in your screen?
Azam, you want to read it? It's okay. Somehow Yusuf's eyesight is all
in a transcallosal approach, you think you identify the corpus callosum and incise it, anticipating that you may now enter the ventricle. But you yet again come across another white and relatively shiny structure with vessels running on both sides. What do you think has happened, and what structure have you incised?
Okay,
Good
what are the
question.
choices?
A, cingulate, B, fornix, C, you don't know, or D, this is the wrong patient.
Okay,
the wrong
two.
surgeon. Number 2, in a transcallosal approach to address colloid cysts causing bilateral hydrocephalus.
Sorry, Imad, why is this so blurred? We can't see it at all. It's really blurred. We can, just barely make it.
Let me share it. Let me reshare it. 1 second.
Please.
Yeah, is it clear now?
Yes.
Much better.
You enter one of the lateral ventricles. Resection of the cyst is seemingly difficult as the septum keeps bulging into the working ventricle. What would you do next? A, incise the septum pellucidum. B, abort the procedure and plan for endoscopy. C, try manipulation and little contusion on fornix is acceptable to facilitate complete removal of cyst. Or D, puncture the cyst to decompress, and that's sufficient.
Okay.
Number 3, you and only you, with no other assistant to blame on, has caused an inadvertent damage to the thalamostriate vein during endoscopic third ventriculostomy. What would happen now? A, patient will definitely have a stroke. B, patient will be aphasic. C, chances are nothing much would happen. but you would be cautious postoperatively, or D, patient will die. 4, superior sagittal sinus thrombosis can occur due to the following reasons except A, placing a retractor on the superior sagittal sinus, B, extensive traction on the dura, C, coagulation over the sinus, D, using 3 to 4 layers of sponge stone over sinus, E, hypercoagulable state.
So it's spongestan, yeah.
Number 5, which of the following is the main complication of the infratentorial supracellular approach in sitting position? Number 1 is air embolism. Number 2, DVT. 3, blood loss. 4, poor vision.
Okay,
Give them a
so
few minutes to do this, or is it already done?
212 people have already done it, so.
Oh, wow, that's fast.
so
Question 1 was the transcallosal approach. You identify some shiny structure, you incise it, and then you come across another white shiny thing with vessels running on both sides. What do you think has happened? What have you incised? So A, far and away, people picked A, you incise the cingulate gyrus. That's the correct answer. So it's often somewhat easy to get lost because the two cingulates tend to be relatively stuck together. You can tell the difference between that versus the corpus callosum because number 1, if you work along the cingulate, there's a cleft in between it, so that's very helpful. Number 2, again, those little perforating vessels that I mentioned that go into the corpus callosum are a key thing to help you identify the midline in the corpus callosum. The pia of the cingulate looks like pia. The white matter of the corpus callosum looks quite distinct. And so it should not be misinterpreted between the two. Oftentimes you get down and you say, okay, these two things are stuck together and I don't want to do the work to get through that. It may be one of the sentiments that people encounter, but you have to peel the cingulate apart to the two sides and between it, and you'll get down to the corpus callosum. Number 2, in a transcallosal approach to address colloid cysts causing bilateral hydrocephalus, you enter one of the lateral ventricles. Resection of the cyst is seemingly difficult as the septum keeps bulging into the working ventricle. What would you do next? Most people chose incise the septum pellucidum, which is the correct answer. About a third of people said puncture the cyst to decompress, and that's sufficient. It might be sufficient, but oftentimes that patulous septum is going to be a problem. So you can just simply cauterize it. One of the key things is where do you cauterize the septum? Where do you do a septum pellucidotomy? The key thing to keep in track of is where the fornix is. As long as you're making it above the fornix, you should be just fine. If you make it below the fornix, or if you're not thinking about where the fornix is, you could injure the fornix on one or both sides, depending on where you are. One of the other important things to think about is, the cavum septum pellucidum and how that alters these approaches. If you're trying to get to the third ventricle, oftentimes it's really convenient to actually have a cavum septum pellucidum, but other times it just adds a little more confusion and difficulty to understanding of the operation. But you can go on to number 3. Number 3, you with no assistance to blame cause inadvertent injury to the thoracic vein. What would happen now? Most people chose chances are nothing much would happen, but you would be cautious post-operatively. I think this is the correct answer. Some people, about 17% of people said the patient will definitely have a stroke. I can tell you that it's not definite based on my experience, but and again, I'm not saying, advocating that it be taken intentionally, but inadvertently, it's probably going to be okay. Superior sagittal sinus thrombosis can occur for the following reasons, except using 3 to 4 layers of sponges over the sinus. That's the key thing to do, is to keep the superior sagittal sinus moist, is a very important thing. Coagulation, extensive retraction on the dura, placing a retractor on superior sagittal sinus, these are all things to be avoided. One of the things that I do, and if you have a Doppler readily available, Doppler the superior sagittal sinus, and then whether you use when you put your stitches in the dura to pull the sinus over a little bit, then you can use the Doppler to listen to the sinus again and make sure that you still have a reasonable flow and the waveform hasn't changed much. That can be helpful in cases where you have a question about that. Number 5, which of the following is the main complication of the supracerebellar infratentorial approach in the sitting position? Air embolism is a complication. I would say that it's a complication that looms large, but I would say in my experience, I would personally say that probably DVT in a sitting position is a higher risk complication, or more frequently occurring complication more than air embolism. I know you get what is the thing they're going to be looking out for. Look based on the duration of the procedure, the fact that there's venous drainage dependent on the common complication, but the more concerning air embolism. First signs of air embolism isn't actually drop in the blood pressure. The drop. You need to tell your anesthesia colleagues who may be entitled CO2. It's not that they're overventilating the patient. It's that air embolism may occur, and it can occur at different phases during the operation. And it can occur relatively early through emissary veins and entraining of air that way, or it can occur after you've been working for a while and the sinus gets dried out, and maybe you can entrain some air that way. So at any stage of the operation, air embolism can occur, and so the anesthesiologists have to be your colleagues and warn you if that's occurring before the blood pressure drops.
Azam, you can continue to comment on this, please. Are you there?
Yes, I'm still here. Should I keep going?
Yeah.
Okay. So the presenter feedback was most people got the right answer here and picked 5. Some people got the wrong answer and picked 4 and 3. I'm just kidding. Quality of the content, 2/3 of people thought that it was a 5, 1/3 thought it was a 4. 2 people weren't paying attention. Rate of the presentation, again, about 2/3 of people gave it a 5, 1/3 gave it a 4, and some did not. Would you hear the same presenter again? Overwhelming majority said yes, so very, very well done, Yousuf.
Thank you, sir.
So we have a total score as well. Like this is the chart for the total scores. 3 of the participants got 0 out of 25. There was points for each question, 5 points for each question. So that's the results.
Okay, very good. I think it's wonderful. I think Chandra, I think we will do your case next Thursday, hopefully. So yeah. we'll be here for the third ventricular anatomy, and the following and the next session is the Thursday week as well. So 2 sessions in a row, Thursday and Thursday week, that we have an anatomy. Have you got what we're doing tomorrow, day after? Ahmad, can you show us?
Yes, sir.
I'll preview.
Okay. This is of tomorrow.
So tomorrow we have Doug Orr talking about lumbar disc prolapse, and Benedict from Germany is going to be talking about a different way of minimally invasive disc surgery. And we have Saad and Shahzad Shamim who will be moderating the session tomorrow. Okay. And on Monday, we have Salim Abdurrauf on talking about anatomy of skull base. And we have Pablo from Spain and Atrenam from Karachi who are the moderators. Do you have anything else or?
No, sir. Right now we have this.
Okay, all right. And I think on Wednesday, we have Richard Asakar and I think Giovanni Grasso from Italy who have their talks. And on Friday, I think we have Rick Fessler to follow that. And then Saturday week, we have, next Saturday, we have the IFNE WFNS Endoscopy Committee. Yeah, thank you for bringing it up here. And Lillian is busy on 17th, so I've asked her to do this on the 1st. So she's going to be talking about spinal tumors and on the gamma knife treatment for that or radiation treatment for that. So this is our future schedule that we have ahead. So hopefully we'll see you guys again Thursday, and hopefully we'll see everybody tomorrow and day after. Okay, pleasure having you all. And as always, Azam and Hasan, you were great. And Yousuf did a wonderful job.
Thank you.
Thank you.
Great seeing everyone. Take care.
Thank you, moderators.